This video is on neurodegenerative diseases. Neurodegenerative diseases. These are diseases that degenerate your neurons. And so you have this neural death, you have this decrease in neural function, and unfortunately these are incurable. So these are incurable diseases that cause neural death and subsequent deficits. Before we talk about these diseases, I want to talk about something else. I want to make sure you understand that these are diagnoses of exclusion. You have to exclude everything first because these are incurable. So if you make this diagnosis, you have to be absolutely sure. You have to rule out things like delirium. Delirium is an acute decline in neural function. It's not a more chronic course like neurodegenerative diseases. It's more acute and it is reversible. That is the biggest thing. It is reversible. This is incurable. That's why we have to make sure we get the right diagnosis. This is reversible. It fluctuates throughout the day. And if you fix the underlying cause of this delirium, then you fix the problem. So there are many things that can cause delirium. You can have head trauma, you can have medications. In old patients, an infection or a UTI can precipitate it. So there are many causes and you have to rule that out before you start even thinking of these diseases, okay? And then there are other kind of chronic diseases that can affect the brain and cause neurodeficits, but they're not particularly brain diseases. These things include things like Wilson's. What's Wilson's? Pause the video and tell me everything you know about Wilson's. Next is hypothyroidism. So hypothyroidism can cause decreased neural function. You can have vitamin B12. Pause the video, tell me everything you know about B12 deficit. Syphillis. And then there's one we talked about in this block, actually. We talked about it earlier. How about normal pressure hydrocephalus? Wasn't that the thing that caused dementia? Wasn't that the thing that caused ataxia? Wasn't that the thing that caused urinary incontinence? Hopefully you didn't forget that. So in a patient that comes in with declined neural function and you don't do a test at least for hypothyroidism, so a TSH, a B12 test, an RPR for syphilis, if you don't at least do those and screen for Wilson's and normal pressure hydrocephalus, then you better have a good lawyer because you're about to get your pantsuit off, because a lot of these are reversible causes. Yeah, and if you make the wrong diagnosis, if you start looking at this before you exclude everything else, then you will give them the wrong diagnosis and you'll basically condemn them because these are incurable while these are curable. Okay, so these are diagnoses of exclusion. Hopefully I made that very, very clear. Now that we've kind of beat that horse to death, let's actually talk about these diseases. There's not a lot of these diseases. There's only a few. And you can break them up into two categories. One of them is brain-specific problems. And this is all due to deposits of abnormal proteins. These proteins that deposit in your brain and cause neural death. Okay, so these are all due to protein deposits. And then the second is just non-brain specific. And the second is more systemic things that can affect the brain. So I'll just put other. And these are going to be non-protein related. There's only one of them here, and we're going to talk about that at the end, but we're going to talk about the brain-specific ones first. These are all due to protein deposition. That is the underlying mechanism. It's toxic. These abnormal proteins are toxic to your neurons, cause neural death, cause that degeneration and deficits. First one, and the most common, is Alzheimer's. Alzheimer's, nobody really knows what causes Alzheimer's. There are two really prevailing theories, and one of them is the amyloid theory. And there is a protein in your brain called amyloid precursor protein that does a lot of things, helps form and repair synapses, which is good, we need that. And this protein is coded by a gene found on chromosome 21. Now this protein can get broken up by enzymes called secretases to form other proteins. And one of the proteins that can be broken down into is beta amyloid. Now, beta amyloid can mutate and deposit and cause neural death, and that is the amyloid theory. There's another theory, it's called the tau theory. And this is because we seem to see a lot of intracellular hyperphosphorylated tau proteins. Holy moly, is that a mouthful. What is that? What is intracellular hyperphosphorylated tau protein? Well, in your cells, you have a protein called tau, and this helps stabilize part of your cytoskeleton, mainly your microtubules. And when it gets too much phosphate groups on it, then it becomes, basically, it goes awry, and it can become insoluble, and you'll start to see these in your cell. Okay, so they're in your cell, that's an intracellular part. They get a lot of phosphate groups, that's hyperphosphorylation and they are your tau proteins. These proteins that stabilize your microtubules. Okay, so your microtubules will die, your cells will die, and you'll see these hyperphosphorylated tau proteins, and that could precipitate cell death. Whatever the case may be, we were not quite sure, and for your intents and purposes, you should be able to recognize beta amyloid in the question stem, or tau proteins in the question stem, or even tau proteins on imaging. Yeah, very easy to recognize. They kind of look like a flame. It's kind of cool. So know it on imaging also. So these can deposit all over your brain, cause your cells to die, cause your brain to atrophy. We said that when your brain atrophies and other things take its place, like your ventricles of your ventricular system, and what do we call that? What's a fancy word for that? Ex vacuo. Ventriculomegaly. Remember, ex vacuo means vacuum, so there's a vacuum of space that's left behind from your brain atrophy, and your ventricles will enlarge to take up that space. So you can have that. These proteins can also deposit in your hippocampus. Your hippocampus, recall, really deals with memory, deals with emotion. So unfortunately, some of the early signs of Alzheimer's is they'll start to forget things, lose their memory. And then that's the memory part. The emotion part, they'll start to, later on in the disease, get more sunken, get more withdrawn, socially isolated. And that's unfortunately the course of Alzheimer's. So memory and emotions. And that kind of goes out the window when you have deposition of these proteins and death in your hippocampus. Last but not least, it can deposit in your basal nucleus of meynert. We talked about this in our neurotransmitter video. What does this make in particular? Makes ACH, acetylcholine. If that's gone, what do you think will happen to your ACH levels? It'll decrease, and that's what you'll find. You'll find decreased acetylcholine in Alzheimer's patients. Now, the majority of Alzheimer's is sporadic, but there's also some genetic components of it. Let's talk about that now. So a lot of the genetic components of it has to deal with the amyloid theory. All right, so let's just recap. You have your amyloid precursor protein found in your chromosome 21, and that gets broken down by these enzymes called secretases to make your beta amyloid, which can deposit. So what are some genetic things that can go wrong that can increase your chances of Alzheimer's? Well, you can have, how about an extra chromosome 21? What do we call that? We call that trisomy. We call that Down syndrome. So in patients with Down syndrome, aka trisomy 21, you have an extra chromosome. So you have more of this protein and you have more of this pathway. So it makes sense that these patients are at increased risk of Alzheimer's. In fact, an incredible risk of Alzheimer's at an earlier age too. So early onset Alzheimer. So we'll talk about a patient, single palmar crease, epicampal folds, mental retardation. What are they at risk for developing when they become an older adult? Alzheimer. This is one that students don't really have a problem with, but there are some lesser known ones. How about preselin 1 and 2? Preselin 1 and 2 are found on your chromosome 14 and 1, respectively. These proteins make up your secretase enzymes. And so if you have a mutation or you have more of it, then you'll just make more of beta amyloid. That makes sense. So this, again, increases your risk. And the last one is apolipoprotein E4. What the heck does this have to do with anything? Is this something that carries fat? Yes, it is. Why it causes Alzheimer's, no one's really sure. It seems to interact with beta-amyloid, it seems to increase its deposition, but just know that E4 increases your risk. However, E2 decreases your risk. Again, the mechanism is not quite sure, but Pathoma, shout out to Dr. Sitar, he came up with a great way to memorize it. Just E4 is a higher number, so it's increased risk, higher risk. E2 is a lower number, lower or decreased risk. These are the genetic components commonly tested, okay? So you gotta know them well. That is Alzheimer's. Now, we can have some drugs that work on Alzheimer's, kind of reduce the symptoms, but again, it's incurable. So these are just more, I guess, symptomatic. What are we trying to do in pharmaceuticals? We're going to try and work on the mechanism of the disease. Unfortunately, we can't really work on the protein deposition. We can't really remove the protein. We can kind of work on the neurotransmitters. We said that you had decreased acetylcholine. You also seem to have increased glutamate. That's your excitatory, that's not, I don't know if that's a word, excitatory neurotransmitter. So you have increased glutamate. Whether or not that's from an imbalance due to decreased neural tissue, or whether or not it's because your cells die and glutamate's released, not really quite sure, but you have increased glutamate. So we can work on these two things. These are the things we can target with drugs. We can try and raise ACH with drugs like ACH esterase inhibitors. That's the enzyme that breaks down ACH. So if we inhibit it, then we'll just get increased ACH. These are drugs like donepezil, rivastigmine. That's the ACH component. The glutamate component, we can kind of block glutamate, or we can block the receptors it binds to. So we can block NMDA receptors. With non-competitive agonists like memantine. Those are just some pharmaceutical ways to kind of alleviate the symptoms, but again, it's incurable. That is Alzheimer's. That's the most common. There are some other ones that you must know. The next one we're going to talk about is frontotemporal dementia. That just gave away what it does, right? Frontotemporal dementia. Previously known as Pick's disease. That's probably the more common name. But frontotemporal dementia is deposition of proteins, because that's the name of the game, in your frontal lobe and your temporal lobe. So if you recall our picture, I swear this is just getting worse and worse as the time goes on. So you have your frontal lobe, your parietal, your temporal lobe, and your occipital. Your frontal lobe, we said, had your executive function, and your motor areas, and your Broca area. Your temporal lobe had your auditory and your Wernicke's. It seems that when you have protein depositing in your frontal and your temporal lobe, it really affects the executive function part of your frontal lobe, and it really affects your Broca and your Wernicke's area, so you get aphasia. So commonly you see aphasia with loss of executive function. This is loss of concentration, problem-solving skills. Sometimes it shows up as loss of inhibition. So disinhibition, they might make inappropriate advances, inappropriate jokes. I guess act in a way that's less mature. So I'll just write, what do I want to write? Disinhibition. And so a patient coming in with progressive dementia, and they're showing these signs, aphasia, disinhibition, you're thinking of frontal temporal lobe. Now, what's the protein that deposits here? The protein that deposits here is going to be your tau protein. Here's that tau protein again. So again, tau protein seems to be a very, very solid hypothesis. This tau protein is a little bit different. It's spherical, not that cool flame-like. And it also is seen more on silver staining. So it's called silver staining spherical tau protein. Or you can have protein called TDP43. Ubiquinated. This is a protein that just binds to DNA, represses transcription. I'm not sure you need to know that, but just know TDP43 is another one. So these are the proteins that cause the deposition, cause the neural death. That is frontotemporal dementia. Next up is Parkinson's. Parkinson's we've already talked about. We talked about when we talked about movement disorders. Your basal ganglia, that's why you had movement disorders, but it doesn't mean it only affects your basal ganglia. So eventually you get dementia. Because dementia came later, we didn't talk about it now, but now we're talking about it. So Parkinson's, you have movement disorder, and then you have dementia later. And what protein deposited and caused Parkinson's? We said it was your Lewy bodies. Remember, those are your aggregates of alpha-synuclein. Alpha-synuclein. Could you have this protein deposit and cause the reverse? Could you have dementia first and then movement disorders? Yes, you can. That sounded kind of Barack Obama like, yes, we can. We call that Lewy body dementia. So it's the same protein, but for some reason or another, it causes dementia first. Yeah? And then you'll start to see the shuffling gait, the resting tremor, the Parkinson's. So it should be very, very easy to kind of pick these two apart from everything else. All right, because it's classic Parkinson's. It's just whether or not the dementia comes first or later. And if that wasn't enough to kind of make the diagnosis easy, this Lewy body dementia seems to also have hallucinations. Things that aren't quite seen in other forms of dementia. All right, so hallucinations is a big one. And the last one for the brain-specific protein depositing causes of neurodegenerative diseases is going to be your prion diseases. Prions are really, really cool. Prions are proteins that deposit. That's the name of the game. But these prions will go on, these mutated prions will go to normal prions and cause them to mutate. They're kind of like infectious proteins. That's pretty cool. So these are your prion diseases, and they are basically infectious proteins. I don't know if I'm using that word correctly. Some infectious disease, doctor's probably gonna kill me for this, but they're more or less infectious proteins. So they cause other normal proteins to become abnormal like them, and then they'll deposit and cause neural death. So the normal form of prions in your brain is called PRPC. PRP, the PR stands for prion, the P stands for protein, C stands for the conformation of it. So prion protein conformation C is a normal one. And if it mutates, it can become PRPSC. And this is the mutated version. And this can go around, find normal protein and turn it mutated. And these will aggregate and form beta pleated sheets. What the heck does that mean? If you recall your protein structure, beta sheets are basically just kind of look like this. So these form these sheets in your brain, deposit there, and they're very, very stable to proteases, things that break down proteins. They're very, very stable, so they just can aggregate and build up and cause neurodegenerative disorders. I forgot I erased it. I was like, what has that point to everything? So when it deposits, it causes vacuoles to form. Your brain will form these vacuoles and start to take on this sponge-like appearance. Sometimes we call it spongiform encephalopathy. Spongiform. This is one of the most rapid forms of neurodegenerative diseases. You get the most rapid dementia, so it can go from weeks to months. Again, it's not acute like delirium. I'm not saying that. I'm saying it's more rapid than the other ones. So this is rapid dementia. So someone can be fine, and then the weeks and months come in, they just take a nosedive. One of the things they can get is myoclonus, or an increased startle reaction. They basically tighten up, or the exaggerated startle reaction if I'm just like chilling here and I'm zoning out and someone, or there's a loud noise and now, I'll get startled. But exaggerated startle reaction is basically like you go over the top. And this is a classic sign. I've seen a lot of questions on it. They'll say a patient has exaggerated startle reaction, progressive dementia. What do they have? They have a prion disease, a spongiform encephalopathy. How do you get that mutated prion? Well, it can just mutate. You can also have familial prion disease. So kind of inherited, and it'll start off as a baby. We'll have trouble sleeping, they'll have insomnia, and they'll have the dementia, the exaggerated startle reflex. So you start them and the baby will just go nuts. You can have it if you deal with brains, if you're a researcher that deals with brains, because it's found in your brain. You can also get it if you transplant things from your head. What do we transplant from your head? You can get it from corneal transplants. So right, corneal. You can get the cow form of it if you, cows that have it, we call that mad cow disease. There's like a big epidemic, I remember when I was younger, of mad cow disease, and it's like, don't eat beef because you might get the cow form and cause encephalopathy, or prion disease. So we call that mad cow. And then the more historical one that I've never seen before in the question stem is that headhunters in Papua New Guinea, or people that eat brains, cannibals, can get it because they eat the brains. So I've never seen in a question stem, no question stem ever said like a cannibal walks into your clinic and is complaining of dementia, no. So if they get a question like that, that's like a give me. So I will say, what do I want to say, cannibal? You can get it if you're a cannibal. So moral of the story, don't eat brains. Those are all your brain-specific, protein-specific causes of neurodegenerative disorders. Now I said there was one more category, and then that was non-protein specific, and that is just vascular dementia. What the heck is vascular dementia? This is when you have infarcts in your brain. Yeah, and your neural cells will start to die, and you have motor deficits. That's kind of an easy mechanism to understand. So if a patient comes in with, this is like vascular. If a patient comes in, history of MI, history of cardiovascular disease, the whole 9 yards, and is having these symptoms of neurodeficits, and you're thinking of vascular dementia. And they like to say it's step-like decline. What the heck does that mean? That means they're doing good. Let's just say there's their baseline neural function. And then they have a infarct, take a dive. And they're in the hospital, they kind of start to recover, okay, now this is their new baseline. And then they have another infarct, because often these patients are at increased risk for another infarct. So they take a dive and they recover in the hospital, they're recovering, okay, now this is their new basal level, and then another infarct to take a dive. So it's like a step-like progression, as opposed to Alzheimer's, which is just a progressive decline due to the protein deposition, neural death. This is step-like, so you gotta know it's step-like, and then the history will kind of give it away, all right? And that does it for your neurodegenerative diseases. Hope you enjoyed the video, hope it cleared things up. See you next time.